Hello everyone. In this video, I'm going to discuss management of miscarriages and most importantly, missed miscarriage. This is basically part 2 of the video. Title is vaginal bleeding in a pregnant patient. In that video, I have discussed how to take a history when a patient presents to you with vaginal bleed during pregnancy, what are the differential diagnoses that you need to rule out, and what are the red flags that you need to look for, what relevant investigations you need to request, and what are the relevant examination that you need to perform. In this video, I'm going to discuss the management of miscarriages because miscarriage is one of the differential diagnoses whenever a pregnant patient presents to you with vaginal bleeding. Okay. Uh, so as we all know that bleeding per vaginum is the most important symptom of a miscarriage. The bleeding can vary from a little bit of spotting or brownish or reddish discharge to frank vaginal bleed, depending upon the type of miscarriage. And it is also accompanied by lower cramping abdominal pain, just like a period pain. Now let's discuss briefly about complete and incomplete miscarriage, and then we will discuss in detail about the management of missed miscarriage. So in complete miscarriage, the patient will tell you that she had an episode of vaginal bleeding, and along with the bleeding, there was passage of clots as well, along with some organized tissue, which is basically the product of conception. Patient will tell you that it was accompanied by cramping, lower abdominal pain, but there is no ongoing vaginal bleed when the patient presents to you. There is no passage of clots when the patient is there in the clinic, and the pain has resolved since then. Okay, when you perform examination on this patient, on abdominal examination, there will be no pain and no tenderness. When you do per vaginal and per speculum examination, there will be no ongoing bleed. There will be no product of conception or clots in the vagina or cervix, and the cervical os will be closed. This is complete miscarriage, and there is nothing that you can do about it. Okay. So your major and most important task here will be to break the news to the patient. And you need to do it in the breaking bad news manner because it is a sensitive news. Okay. Now, regarding incomplete miscarriage, the history might look like the patient had an episode of vaginal bleeding, which started a few hours ago. She passed some clots, but and there was cramping lower abdominal pain, but she is still bleeding when she is presented to the clinic, and she is still in severe pain. Okay, this is incomplete miscarriage, and this is basically an emergency because if the patient keeps on bleeding, it can become life-threatening. So if you are in GP, you will refer this patient immediately to the hospital. If you are in the hospital, you are going to admit this patient. You're going to, of course, you're going to do examination. On examination, there will be abdominal pain and tenderness. There will be, on per vaginal and per speculum examination, there will be clots and there will be ongoing bleed, and there will be clots and tissue that is product of conception in the vagina and cervix, and the cervical os will be open. What you are going to do is to admit this patient, check her vitals if her BP is low, you know, if BP is low and pulse is high, you are going to start this patient on fluids as well. To maintain the hemodynamic stability, you are going to request blood grouping and cross match. And arrange blood for the patient, and you are going to administer antibiotics to prevent infection. You are going to give pain relief, and you are going to do dilatation and curettage or suction and curettage to remove the product of conception from the cervix and the vagina and also the uterus. There's nothing that you can do to stop miscarriage here as well. The miscarriage is already it has progressed, and your your management here is basically focused on controlling the bleeding and preventing infection by removing the product of conception and giving antibiotic and also managing the pain. Again, you need to break the news to the patient in a sensitive manner. Now, missed miscarriage, it is the most difficult one to diagnose because it presents with weak symptoms. So about bleeding, there may be a little bit of bleeding, like maybe a little bit of spotting or even brownish discharge, which is difficult because this much of bleeding a patient can normally experience in the first trimester. Okay. So you are not sure whether to call this bleeding is a sign of miscarriage or whether it can be because of the normal implantation bleed. And then there may be a little bit of lower cramping pain, lower abdominal cramping pain, or there might be no pain at all. What is the most important thing here is the patient will notice that they are no longer having pregnancy symptoms. So there is no morning sickness, which was previously there. There is no breast tenderness, and there is no, cravings, mood swings, etc. So the patient will tell you that they feel like they are no longer pregnant. There might be a history of a little bit of brownish discharge or a little bit of spotting. Okay. So what you are going to do here is you are going to explain your provisional diagnosis to the patient again in a very sensitive manner, and you are going to address the concerns at the start of your management. Now, depending upon the setting, your management will differ. So if you are in the GP, what you are going to do is you are going to refer the patient to the early pregnancy assessment unit, and there the patient will be seen by nurse practitioner and gynecologist. What they are going to do is they will reassess the patient, they will do an ultrasound scan to check the heartbeat of the baby, and they might also do some blood tests to see the level of beta HCG, which is a pregnancy hormone in the body of the patient. So they are going to do two blood tests 48 hours apart to see whether the level of beta HCG is increasing or decreasing. So if the level normally needs to increase, but if the level is decreasing, then it means that the patient is no longer pregnant, and this is a case of miscarriage. Now, referral again, it can become complicated. So, for example, if the patient is less than 6 weeks pregnant, the patient is less than 6 weeks pregnant, and she has presented to you with in the GP surgery with loss of symptoms of pregnancy and a little bit of spotting. Then, if you refer her to the pregnancy assessment unit, early pregnancy assessment unit, they won't be able to check the heartbeat of the baby on ultrasound because it's too early to see the heartbeat of the baby on even per vaginal ultrasound scan. So they might need to do the beta HCG testing 48 hours apart to see if the level are increasing or decreasing, and may need to follow her up in 2 weeks again to definitely diagnose this as miscarriage. Okay. So diagnosis and miscarriage can be challenging, but you need to tell the patient your provisional diagnosis that you are suspecting this, and that you need to refer to the early pregnancy assessment unit to be confirmed. However, they might not be able to confirm just now because the pregnancy is very early on. So she might need to be followed up again within 2 weeks. Okay. Now in hospital, so if you are in the hospital, what you are going to do for this patient? So in hospital, you will be able to confirm whether this is miscarriage or not, because you will be able to do ultrasound scan and you will be able to do blood testing beta HCG 48 hours apart. So once the diagnosis of miscarriage is confirmed, then you are going to explain the results in a breaking bad news manner. So you are going to follow the spike protocol, checking for support and everything before you tell her the results, and breaking the news in layers and everything. You need to acknowledge the emotions because you need to be aware that this is quite an emotionally traumatic event for the patient. You need to explain to the patient that pregnancy loss is common, and often the cause is not known. But you must explain to the patient that she must not blame herself because there's nothing that a woman do to cause pregnancy loss. Okay. Um, Ask about the idea or understanding surrounding the management option. Is there anything on her mind how the management should proceed like? And then ask her if she would like to know about the management option. So basically, we have three management option in cases of miscarriage: expectant management, medical management, and surgical management. Expected management. So in expected management, what we do is we wait and watch. Okay, we wait and watch. We wait for the body to naturally to we let the nature take its own course, and the body will naturally expel the product of conception. Time to complete miscarriage can be unpredictable, and it might take several weeks. What symptom the patient can expect is the spotting might increase, and She might experience bleeding up to 2 weeks. There might be cramping pain, just like a period pain. Um, she need to be followed up. If we are going to take the wait and watch approach, we need to follow the patient up and we need to do continuous beta HCG monitoring every week. We need to explain the risk associated with this approach. So there is a risk of failure, and then you need to do, so the body might not expel a product of conception at all. So then you need to either do medical management or surgical management. There can be an increased risk of retained product of conception requiring surgical intervention. This method is contraindicated if there is IUCD in situ. So while taking your history, you should ask the patient whether she has an IUCD in situ. So this is rare, but sometimes the patient can become pregnant with an intrauterine device in situ. And once the patient is pregnant, then there is no way to remove the IUCD. Okay. So in that case, it is contraindicated if the patient then undergoes a miscarriage for you to follow the expectant management approach. Okay. Then you need to surgically remove both the pregnancy and IUCD. All right. Medical management. Medical management involved giving two medication. One is misoprostol and one is mifepristone. What misoprostol will do, it will cause uterine contraction, helping to expel the uterine contents, and mifepristone increases the effectiveness of misoprostol. Okay, so misoprostol will induce uterine contraction. It will help to expel the pregnancy tissue, and mifepristone, it increases the effectiveness of misoprostol. What to expect? There will be some bleeding, which is heavier than the normal period bleeding, and there will be cramping abdominal pain, which is more severe than the period pain, but patient will be provided pain relief medication. Risk of failure. So there is a risk of failure associated with medical management as well. There can be retained product of conception, which will then require surgical intervention. Again, medical management is contraindicated if there is IUCD in situ. Okay. Surgical management. Surgical management is called dilatation and curettage or suction and curettage. It does involve going to the operation theater and having general anesthesia. It involves passing instruments via the vagina and the cervix into the uterus to expel the pregnancy tissues, which are then sent for histopathological examination. Um, so what is the advantage here? The advantage here is there is more immediate outcome and there is less requirement for follow-up. There is no prolonged upper vaginal bleeding for weeks as in medical management or expectant management. The risk associated here is infection, organ damage or perforation, and the risk associated with general anesthesia. So you need to explain all these to the patient in detail and then ask the patient, you know, what sort of management she would like to follow. And yeah, so that was all about management of miscarriages, and I will see you soon in the next video.